everyone. It's great to see you here in the midst of some phenomenal keynotes this morning. I'm super proud and impressed to be giving them to you this morning as such a gift. I want to start by saying that Rhett and I go way back. When I was a social services director, we were trying to struggle with how to address child well-being. Like, how do you measure that? What does that look like? And luckily, he had a relationship with a very smart gentleman before me, which made my path much easier. But we were able to partner together to do some really, really cool things to show how collective impact models and good evaluation and good implementation science can really change things in a way that sets the stage for improved health outcomes. And so I want to thank you for that, Rhett, really. But this morning, I have the pleasure of introducing him, and I want to do that justice. But many of you may know Rhett, and you'll also learn so much more about Jon today as well. Two phenomenal individuals, but they're really looking at new models of care and funding and what that really looks like. When governments come together, when the private sector comes together, when systems come together to really address tough issues. One, how do you fund those? Two, how do you measure them? And three, how do we show that they actually have a really good impact on the populations being served? And so Rhett is the president of the Duke Endowment. He joined in 1992 as an associate director of healthcare and became the director of child care programs in the area in 1998, and was named vice president of the endowment in 2009. He also served on many committees in North Carolina and South Carolina as well, I'm sure. If there's a space where value-added impact and conversations about improved well-being occur, you might find Rhett there. But currently, he is really involved at the local and national level and making a difference in North and South Carolina. You'll also hear, and he'll introduce and transition over to Jon Baron, who's the president and chief executive officer of the Coalition for Evidence-Based Policy. He was twice nominated by the president and confirmed by the Senate to serve on the National Board of Education Sciences, and was also the board's chairman during the last year of his term. So if you think about these two together, they very much are a powerhouse, and we're very fortunate to have them with us today. But now as Rhett comes before you, I hope you'll give him a warm round of applause, and then as he transitions to Jon, the same. So gentlemen, thank you for being here.
Thank you, Jon, for those kind and overly generous remarks. I appreciate your kind introduction. It reminded me of when I first met Jon. I was on a panel somewhere in North Carolina talking about child welfare with his predecessor, a gentleman named Bobby Boyd in Catawba County. And all during the panel, I'd say something, and then Bobby would say something that I thought was just remarkable. And I made a little note on the side of my notes, and I said, I need to go meet that gentleman. And he put in motion some really important work that we did to try to take care of kids, children, and families as they return back to a permanent setting, trying to wrap them with support. And it's something we've tested, and the basic model has been replicated now across Carolina and the Carolinas in a couple of sites. So it's been great to work with you, so thank you again for that. And I look forward to I'll introduce Jon Baron to you momentarily. What I want to do is give you a brief overview of the Duke Endowment. It'll kind of give you a sense of who we are and how we think about things. And then I want to lift up an example of where we have made mistakes. And believe me, we've made a lot of mistakes. I've made a lot of mistakes. But the most important thing, I hope, is that you learn from those mistakes. And that's what we're trying to do. And I want to convey that today because I think it's an opportunity to move forward, particularly with government, in a way that we haven't been able to in the past. So I'm going to see if this works here. So just to tell you a little bit about the Duke Endowment, the story of the Duke Endowment begins with this man, James Buchanan Duke, who made his fortune first in tobacco, creating the largest tobacco company in the history of the world. And then, as his tobacco company was being dissolved through antitrust legislation in the early 1900s, he began investing in hydroelectric power. And he formed the Southern Power Company, which became the Duke Power Company, which we know today is Duke Energy. So he really made two massive fortunes. And it was a rags to riches story. Post-Civil War, his father came back from the Civil War. Folklore says that he had 2 blind mules, 50 cents in his pockets, and some leftover tobacco. And from those humble beginnings, they did quite well. 1924, a year before James Buchanan Duke died, he signed the trust indenture of the Duke Endowment to give back to those communities in North Carolina and South Carolina that helped him to amass his fortune. The initial investment was $40 million. A year later, when he died, his estate put another $67 million in there. So today, that $100 million is now worth $5 billion, and we've given away about $5 billion as well. And it's a testament to the American economy in the 20th century, frankly. In his trust indenture, let's see if that went forward. There we go. In his trust indenture, James Buchanan Duke was very specific. So a trust indenture, it's a document that takes about 45 minutes to read aloud, which we do to our board each year per his instructions. So so staff can be reminded of his wishes. It's a pretty good technique to ensure that we don't drift too far. But he gave very specific instructions. He named 4 schools of higher education: Duke University, Davidson College, which is just north of Charlotte, Johnson C. Smith University, and HBCU in Charlotte, and of course Furman University here in South Carolina. He also wanted to help orphans and half-orphans. Today, we call it our Child and Family Wellbeing Division, where we try to help families who are either involved with the child welfare system or who might be at risk for entering the child welfare system, usually because of child abuse and neglect. We try to put more money upstream toward prevention and intervention. We also support health care in the 2 states. At inception, way back 100 years ago, we were we were trying to build hospitals, particularly in counties that previously did not have a hospital in the 146 counties of North Carolina and South Carolina. Today, we're trying to work with hospitals as they try to learn how to work more in community, how to address social determinants of health, and how to promote health as opposed to treating illness. Now, we also help them to improve on treating illness as well, because sometimes that's inevitable. And then lastly, we support rural United Methodist churches in North Carolina. We're not sure why Mr. Duke left out South Carolina in that regard, but he did. And the Dukes were devout Methodists, and James Buchanan Duke once said, excuse me, if I ever amounted to anything in life, it's because of my father, Washington Duke, and the Methodist Church. So I think the Methodist Church and faith is really the impetus for this family's philanthropy. So shift gears to today. I use this slide a lot, and if any of you have been to some of our recent centennial events, because we are in our 100th year now, you've seen this slide, because I think it captures the essence of the Duke Endowment today. We are a foundation that is committed to donor intent. As I said, we read the trust indenture aloud to the board and staff once a year. And yet we also know that we have to make adjustments to remain relevant in the world today. And Mr. Duke, fortunately, knew that we would, so he gave our board full discretion. It's interesting. There are folks out there who will applaud the endowment and say, there's a foundation that pays attention to donor intent. There are others who will be critical and say, how in the world could they be following a document that was written 100 years ago that surely is no longer relevant? And the way we manage that is to try to strike this balance between being faithful to his guidance and stay within his lanes, but doing it in a way that makes sense in today's world and making tweaks and adjustments and adaptations. One such adaptation was in 2017 when our board approved an emphasis on early childhood, on 0 to 8. They were not creating a 5th division of the endowment. They were not rewriting the endowment. Rather, we believe that if we do a better job of working with children and families in those formative years, because it's brain science tells us just how critical the early years are for children and families. But if we do a better job there, we'll further the ends that Mr. Duke aspired to. So for instance, If we invest more in children and families, we'll have stronger families and fewer children in child welfare. If we get families and children off to a healthier start, that'll lead to a healthier population. If our churches in rural communities do this work, they'll be more relevant in their communities, and the communities will be stronger. And of course, if we have children reading at grade level and performing at math by third grade, that's a milestone or a path on the pathway to post-secondary education and a more educated society. 0 to 8 is also an important strategy, not our only strategy, but an important strategy toward addressing issues of race and poverty, which are, as we all know, stubbornly persistent in the Carolinas and across our country. It's a longer term play, but we believe that if we can do a better job of getting children and families off to a good start and building skills and equipping them with skills and establishing healthy habits, we believe that may be the best approach. That may be the best approach toward ensuring that everyone has an equal opportunity to live into their potential. Now, one example of that, of investment in early childhood, and this is the main point I want to make today, is nurse-family partnership. And some of you in South Carolina, I see Sue Williams out there, and we've had quite a few conversations around nurse-family partnership, trying to get it established in South Carolina. So nurse-family partnership, if you don't know, is a home visiting program that has at least three high-quality randomized controlled trials dating back to the 1970s. We recently had a randomized controlled trial here in South Carolina that did not go as well, and I'll mention that momentarily. But it's got strong evidence, and we've got it established in North Carolina, South Carolina. It's also a good example of how we've made some serious mistakes in terms of how we work with government, and that's what I want to focus on here for the rest of my comments. So here's a map of North Carolina, and the blue counties, there are 100 counties in North Carolina. The blue counties, there are 29 of those that still have nurse-family partnership operating in the Carolinas, and the Duke Endowment is no longer supporting it. So in the foundation world, that is the Holy Grail, that we start something, the state picks it up, and it gets sustained. And we should be proud of that, except at one point there were more blue states than there are now, so we've had some attrition. And also the way we did it probably deserves some scrutiny. What we did to get recurring dollars for nurse-family partnership is that we went over the administrative body, the state level, and we went directly to legislators. And we did not lobby, but we educated legislators in North Carolina on why nurse-family partnership was such a great program. It saves money and it produces better outcomes, as proven by some randomized control trials. But what we did not do, or what we created there, let me put it that way, that led to some recurring funding. But what we created, we never built the buy-in by the administrative, the government, those who have to, DHHS, who have to actually run the programs. We never really created buy-in in the local health departments. North Carolina is a decentralized model in terms of its autonomy, and so each county has its own autonomy. We never created that buy-in. So in essence, because we and NFP, Nurse Family Partnership, also, they did hire lobbyists to help promote this. But because we were successful, we essentially foisted it upon those who we expected to deliver the program. And I don't mean this in a pejorative way, but we essentially made local health departments that were delivering the program mercenaries. As long as the money's there, they'll do it. But they never really bought into it because many health department directors, I think understandably, don't believe that NFP fits really that well within their philosophy of how to deliver care. It's probably too intensive. It's probably too narrow. But so it was always just an adjunct. And so instead of getting assimilated into the system, instead of being part of, hey, how do we think about this and how do we change it? Instead of seeing atrophy, and I should have shown that map how many we had and showing you how many we lost. Instead of atrophy, it should have been growing maybe if we had done it the right way. If we had built, if we listened to everyone, which my wife says I need to do in every case, but if we would listen to everyone and work with them, we may not have had success as quickly, but we maybe had more enduring success. Let me give you an example, if you'll go back to your slides yet, to South Carolina now. So in South Carolina, we had a pay for success contract, and some of you probably have gray hair like I do remembering this. So you could say that we did a better job with Nurse Family Partnership in South Carolina because we spent 2 years, literally 2 years, in negotiating a deal, which I'm going to walk you through, a pay for success deal in South Carolina to expand and embed South Carolina, Nurse Family Partnership in South Carolina. So we came together and we decided on an evidence-based program. NFP was our selection. We decided the reach that we wanted to accomplish over 4 years was 4,000 mothers that would be enrolled in the program. One stipulation, and this is going to be a common theme as I tell you this story, the state wanted 65% of the mothers to come from the 200 lowest income zip codes. We agreed, we in Nurse Family Partnership, the National Service Office, agreed with that. What they were trying to do is get broader coverage so it would have some appeal to legislators across the state. What it may have done is made the operations of NFP a lot less efficient. I think NFP, Nurse Family Partnership, works better in higher density communities, not as great when you're traveling around these country roads, not as great in rural communities. So that requirement, I think, added another onus onto what we were trying to do. We also agreed on outcomes. Now look at these outcomes: 13.5% reduction in preterm deliveries, a 23% reduction in childhood injuries that resulted in hospital care, and an 18% reduction in repeat pregnancies within a 2-year period. Those are pretty aggressive targets. And what we agreed to that because the state, I would argue, out-negotiated it. So why would they out-negotiate us? Beth over there smiling. And by the way, I'm not being critical of Christian Sorer in the state at all. He did his job and they did their job to create a great deal for South Carolina. So I'm not being critical. But it's clear that we wanted this. The National Service Office, the Duke Endowment, the other funders, we wanted this more than the state wanted it. So at almost every impasse, I felt like we yielded. And there's a story there. If we'd been equally invested in trying to do this, we might have agreed to terms that maybe are a little more generous. If it sounds like I'm setting this up and explaining why it failed, I'm doing that. All right. The other thing is that we calculated a projected savings based on these reductions. If my math is right, and I think my memory's right, if we had hit 44% of our targets, the targets here, the state of South Carolina would have broken even. Our capital stack was such that we had a $13 million Medicaid waiver. I think $4 or $5 million of that was South Carolina money. The rest was federal money. We had $17 million in philanthropy, and we also capitalized on $6 million of McV funding, maternal home visiting funding from the federal government. So a $36 million capital stack. South Carolina had $4 or $5 million. If we had hit 44% of our targets, South Carolina would have broken even. Again, kudos to Christian Sorer for a great negotiation. The problem is, if we didn't hit these thresholds, we had to hit 100% or nothing. There was no graduated. If we hit 75%, we get some payment. And I'll show you in a second what I mean by payment. We had to hit 100% or we lost. And meanwhile, if we hit 44%, the state of South Carolina is going to be better, all financially. So we set up a randomized control trial. In addition to the 4,000 mothers that we enrolled, we also enrolled 2,000 mothers on the controlled group side. That too, by the way, is a bear to try to enroll that many mothers into a program over a 4-year period. That's a lot of work, and we struggled with that. And it may have impacted those whom we enrolled. I think higher functioning mothers were probably easier to enroll, so I think we had a higher functioning group than normal. And then finally, the state agreed to escrow, I think with Children's Trust Fund, $7.5 million that if we did hit our targets, which by the way, we did not hit our target, we didn't even get close, by the way, then the state would have reinvested that $7.5 million back into the program, in which time we would have gone to the legislature and said, look, by your own data, we're getting you better outcomes and we're saving you money. We didn't have to tell that story because that did not happen. So what happened here? Again, I think it's, in this case, we did plan with government, you could argue, really quite intensively. I'm not sure we had equal interest. I think they were a little more dispassionate, which is probably a good place to be when you're negotiating, than we were. So we didn't engender that kind of equal desire and investment. And we also just dealt with the policy level. So again, we left out the administrative team, the people who are going to be doing the work. We left out the people on the ground, the nurses. We didn't get any of that as we were doing all this. You know, I thought it's the greatest thing in the world, all this high-level negotiation, but we forgot about how it gets delivered on the ground, and we didn't cover that, which leads me to my last slide. Somehow we, and the Duke Endowment has to own this. I think we're classically like all philanthropy, but we have to own this. Somehow we have got to move away from this transitional negotiations with state, and show up, oh, we've got nursing home partnership, look at this great program, and try to sell it to them. Instead, we've got to move to more joint planning. We've got to move earlier in the process. And we've basically got to say to the state, look, we all want better outcomes for children and families in South Carolina and in North Carolina. We got to say, can we agree upon that? I'm assuming we can. Then we've got to figure out, okay, what are your priorities? What are our priorities? What are your non-negotiables? What are ours? And somewhere in that overlap on this Venn diagram, we've got to think about where we can do work together. We also, back on that, my last point, we've got to think about communicating with all levels of state government and all levels that are going to be involved in this project. So if we just hang out with the policymakers and get all excited about that, but we don't bring in the administrators who are going to have to run these programs. We don't bring in the actual nurses, in this case, the providers who are actually doing this work. If we don't bring them into the conversation, we're going to keep repeating the same mistakes that we've done in the past. And finally, this is something else that never occurred to me at that time, I'll be honest. We've got to bring in the voice of those whom we're trying to serve. So this looks a lot more complicated, I think it will be, but somehow we've got to find that sweet spot of hearing the voice of those whom we're trying to serve, hearing all different levels of government, and then understanding what our parameters are and being forthright about those. And we've got to spend more time negotiating and having conversation. If it doesn't work out, which I suspect there'll be a high fail rate where we just have to walk away, then we walk away. But I don't want to go forward with another project unless we have equal commitment and excitement on the part of government, all levels, on the part of the people whom we're trying to serve, and the part of the Duke Endowment. To me, that's really the only way forward. I think that's all I have, but I look forward to, I think we have time for question and answers at the end, so I'll be happy to answer any questions you may have. Now, I have the pleasure of turning it over to Jon Baron. And Jon, as our opening slide said, runs the Coalition for Evidence-Based Policy. I first met Jon 20 years ago in a meeting in Durham at Duke University. He is a leader of trying to work with government and with, originally at the federal level, but now he's starting to work more at the state level to try to encourage them to be more thoughtful about where they put their resources toward programs that have stronger evidence so that we can all do what we want to do with our lives, and that is create better experiences for children and families and people who need our help. So Jon, with that, I'll bring you up. Thank you.
Thank you, Rhett. So I am president of the Coalition for Evidence-Based Policy. We are nonprofit, nonpartisan. Our mission is to tackle major social problems using rigorous evidence about what works. We're not affiliated with any social programs or program models, and have no financial interest in any of the policy ideas that we advance, so we serve as an impartial expert resource to governments and philanthropies on evidence-based programming. We've been around for a long time, since 2001. We've gotten a lot of initiatives, evidence-based initiatives, enacted into federal law in teen pregnancy prevention, K-12 education, early childhood, and so on. And following your lead, Rhett, we have made some mistakes, learned some things that have worked well and not so well as part of those evidence initiatives, and I'm going to describe a little bit of that. All right, I'm going to start out by giving an overview of a new initiative that we're partnered on with the Duke Endowment in the Carolinas, and in Maryland, we're partnered with another philanthropy, Arnold Ventures. It's called shared funding. In Maryland, it's called matched funding. Its overall goal in one sentence is this: to use philanthropic matching funds from the Duke Endowment or Arnold Ventures to catalyze government investment with matched public funds in scaling up programs that are either proven effective or highly promising. So what do we mean by proven or highly promising? These are social programs that have been shown in large gold standard randomized controlled trials to produce important lasting improvements in people's lives. There are not a huge number of these programs with top-tier evidence, and they're not going to solve every social problem in the Carolinas or in Maryland. And this isn't the universe of effective programs. These are programs where there's credible evidence of a sizable impact. They've been rigorously evaluated and shown to be effective. But there are enough of these programs with top-tier evidence that if a state were to adopt and implement them at scale, faithfully to the program model, they could really move the needle in a very significant way on some major social problems. I'm going to give you examples in one moment. And that moment is now. Let me give you a couple of concrete examples. So a highly promising program that the Duke Endowment and we are seeking to scale in the Carolinas is the Triple P system that some of you may be familiar with. It's a system of parenting programs for families with young children, which seeks to strengthen parenting skills and prevent dysfunctional parenting. It was evaluated in a randomized controlled trial in South Carolina. 9 counties were randomly assigned to implement Triple P countywide. 9 other counties were randomly assigned to a control group that didn't implement Triple P. They implemented usual community services. And the study, which was published about 10 years ago, found that the program reduced countywide rates of child maltreatment, hospitalizations for child maltreatment injuries, and foster care placements by between 10 and 30%. So it's a very sizable effect. In Maryland, we are partnered with the governor's office and with Arnold Ventures to expand a proven math tutoring program for 9th graders in high poverty schools, high dosage tutoring that has been shown in multiple randomized trials in New York City and Chicago to move students ahead by almost a full grade level in math during 9th grade, and the effect is still there. The treatment group still far exceeds the control group 2 years later at the end of 11th grade. So here's how a shared funding initiative works at a high level. The philanthropy, meaning Arnold or the Duke Endowment in this case, offers to provide philanthropic matching funds to help scale one of these top-tier programs. The philanthropy's award is conditioned on 3 items. Number 1, picking up on what Rhett just described, a state or local government partner from the very beginning that is willing to that agrees to put in matching public funds to expand the program. In Maryland, for instance, the State Department of Education is putting in $9 million to expand that math tutoring program in Baltimore City. Arnold Ventures has matched that with $9 million, so it's an $18 million initiative in Baltimore City schools. Number two, the agency agrees to work with us, our organization, over time, to incorporate evidence-based criteria into their future funding announcements, into their RFPs, for instance, with the goal of institutionalizing and sustaining the government agency's prioritization of funding for evidence-based programs, along with rigorous testing of new programs, once the philanthropic funding winds down. So the philanthropic funding is not designed to be there in perpetuity. It's designed to be a catalyst and government ultimately to pick up the mantle. And number three, for programs that are highly promising but not quite proven, the evidence is not quite definitive, Triple P is an example, the philanthropy will commission a replication trial, another randomized trial, to see whether the sizable effects found in the initial research can be reproduced as part of the scale-up. I should also mention that in addition to the shared funding initiative, both philanthropies and other philanthropies as well, another we're working with, Ascendium, are interested in building new evidence, not just scaling what's been shown to be effective, by funding rigorous evaluations of promising programs that government is paying for. So this is not match funding for program delivery, but if government is paying for the program delivery, the philanthropies will often pay for the evaluation. The goal is to grow the number of programs with top-tier evidence over time. So those are the three elements of shared funding. Let me close with lessons learned. We've been at this evidence-based reform effort for many years. Shared funding is focused like a laser beam on finding successes. We want, at the end of the day, when the replication trial findings come in, we want many, hopefully most of these, to show meaningful improvement in people's lives in a definitive study. It seeks to avoid the pitfall of some past efforts, like the Federal Teen Pregnancy Prevention Program and others, which had too low of a standard. Those didn't focus on expanding top-tier programs. They expanded programs that had more preliminary evidence. And they produced a long series of disappointing replication findings. But by that I mean 80 to 90% of the trials found that the program produced weak or no effects compared to what the control group was doing, So the lesson that we took from that is, for the scale-up, for the match funding, look for a really strong signal in the prior research that this thing can move the needle, can really improve people's lives, and also focus in that other basket I talked about on growing, through rigorous evaluation, growing the number of proven and highly promising programs over time. So we're not just talking about a relatively small handful 10, 20 years from now. And that's what I've got. Thank you. So I think we're open to questions, or how do you want to do this?
So I think I'll try to do the Phil Donahue thing. For those of you under 40, you have no clue what I was just talking about. But the floor is open for questions from anyone, and I'll be able to make rounds.
I really appreciated the evidence-based talk we just had, and I'm going to show my Medicaid background. What's the match rate in your matching program?
I'm sorry, if you could speak up.
Yeah, I'm interested in the match rate. So when you match public expenditure, what percentage of the dollar spent from the public do you match?
In Maryland, at least, where we have a concrete example underway, it's 1-to-1, a 1-to-1 match, and it's a cash match.
I would add, too, I think we're willing to do that for longer than what we traditionally done. So the example in South Carolina, that was a 4-year. I think we've got to go farther than that, particularly if we're getting good results along the way with the concurring evaluation.
Good question. Any others? Thank you.
Curious When you're looking at a program like Nurse Family Partnership, if I'm saying that correctly,
You are.
how often do states that you're looking to work with look to other states who have already implemented that model and have seen success? Is there collaboration amongst decision makers between state to state?
I don't have a sense of that. I suspect they're aware of that, and then NFP does have, Nurse Family Partnership, does have a national service office, so they certainly should make state leadership aware of other states that could do that. But in terms of how much of that's transferable or what you could learn, I don't know. Do you have a sense?
Well, I think I think it depends, if I understand your question correctly, a lot on the folks the government agency one is working with. Some public officials are very open to outside ideas from other states and bringing them in. Sure, it's a great idea, let's bring it in, let's do it here. Others think more along the lines of, we want to do our own thing. Or we've got something that sounds kind of similar, can't we do that? Will you match the funding and all of that? So it's both. But I think the more enlightened, if I may say it, public officials are open to both, but really are looking for the best ideas from anywhere, including from other states, and importing them to their state. And that's certainly how the governor of Maryland and the governor's office is looking at it.
Any other questions? Hands raised.
Good morning. No question, but just a comment, Mr. Mabry. Thank you for recognizing the importance of including individuals with lived experiences, because that is so key. So I appreciate it at the end of your presentation that you did highlight that.
Well, thank you. I will say that I'm not exactly sure how we do that either. It's one thing to say it, and I do think I agree with you. It's critically important. Actually, how do you incorporate that feedback in a way that helps us? We've got to figure that out. In fact, when I sat down, I was thinking, maybe you have to have conversations at the policy level, and maybe once you get there, before anybody goes further, maybe you have something like this where you bring in all those folks who would be doing the actual work and kind of hear from them what they think would happen. And maybe you have something similar for people in the communities that you're targeting. I'd love to hear how we actually incorporate it, because it's easy for me to say it, but we do need, it is critical. I agree with you 100%.
Thank you. Any other questions? Go ahead.
Good morning. Both y'all mentioned the Holy Grail kind of being you stand it up and then government takes it next or to the next level. And I worked in government a long time here in this state. I was just curious, do you ever have an example where government was completely, not bypassed, like you said, that kind of bit you on NFP, but where a corporate or a private entity took something and it ran on its own, completely private funded?
So have we ever had something outside of government that's been replicated?
It got sold and some private entity loved it and bid it and ran with it. And
Yeah, we have had that. I'm trying to think, in South Carolina, although I do think government money helped with this, telemedicine, we started that with some small private grants with private hospitals that later got picked up by Governor Haley and taken across, and then consequently in North Carolina as well. So, and it happens a lot in healthcare too, because you have Atrium Health, and you have Novant, and you have the systems here in South Carolina as well, that what they can do is take it and scale it within their system. So if one hospital picks up something, they can then say, wow, we need to send this to our other 17 hospitals across the state. So it happens there. Really, it's easier there because they're command and control, and they say, look, this worked. Now we're going to push it out to our other branches. I think that's probably the most obvious answer. Tamika Williams is in the audience and oversees some of our child and family well-being grants. I don't know, do you have an example of any good examples of one where the private sector ran with something that we tested and improved?
Oh my goodness, oh my goodness, oh my goodness, oh my goodness.
Sorry, I'm sorry. I put you on the spot.
No, I had to think about that, Rhett, in terms of, and I was thinking about my question that I had for you, but private sector running with something. Anything pop in your mind, Christina?
Well-
Like it's harder. There's so many things. It's hard work to do. I think that's the thing. And I think we've made a number of investments and then trying to make sure, and as I'm thinking about it, I'm trying to come up with something that, they've been able to have something that's. Now, I have something in Mecklenburg County that I think about that the government has taken up, that we did some initial funding in, and they made some significant investments around youth that were aging out of care. Yeah. And they did that, but I'm struggling right now to think about the other thing.
Keep in mind, though, so if you think about the child welfare system, we have about maybe $10 to $15 million to give away each year. In North and South Carolina, total public expenditures on the child welfare system is close to $1 billion. And in child welfare, it is the elephant in the room is government. In healthcare, they're comparable proportions. We have about $50 million to give away in North Carolina and South Carolina every year. In North Carolina and South Carolina every year, $200 billion. We have 50 million, $200 billion is spent on healthcare in the two states. So in those two areas of our work, government is what we've got to figure out how to work with better, and frankly with less hubris, less coming in saying, oh, we know the answer, and more just being determined to sit down and work out something together.
I would just add to that, and I agree entirely, government is the 800-pound gorilla. Let me give a quick example. There are 2 job training programs that have been evaluated in randomized controlled trials for low-income workers and been found to produce large, sustained improvements in their economic well-being, like 20 to 40% improvements in earnings over a 7 to 10-year period. They, based on those results, in part they've gotten a lot of money from private philanthropy, not government. They don't work with government because government, for a lot of reasons, the workforce development system is not set up to fund. It's just way too complicated for them to work with government. We're trying to change that because government is by far, so these programs get 95% of their funding from private philanthropy. Even though government is by far the largest source of funding for job training programs for low-income workers in the United States. It's a crazy situation. We're trying to change, in Maryland and other places, we're trying to work with government to try to change the public spending streams so that they start prioritizing and funding programs like this that have credible evidence of meaningful impacts.
I know we're time's up. I just thought of one. YearUp is a program when you talked about job training. So YearUp, a program is largely funded by philanthropy and by businesses, Bank of America in Charlotte's situation, that contribute to the program because it becomes a feeder, a recruiting line. And what YearUp does is work with, they have a program embedded in local community college that trains folks who are high school graduates and prepares them not for bottom level jobs at Bank of America, but actually prepares them for jobs that have a career path. And it's about a year-long training, and then YearUp negotiates with Bank of America, which sees it as a stream of employees that they can do. That's where the private sector and business certainly have supported. That's in 20 communities across the country right now. Sorry. Yeah.
Well, I hope all of you really got some good ideas from this. I mean, the whole purpose of this town hall session throughout the day is really to think about thought leadership and how you bring good ideas back to your communities and really think about what government, what the private sector can do, but also what our community-based organizations and nonprofits can do with persons of lived experience in the conversation to really use and harness collective impact models for the betterment. We can't do this by ourselves, no one system. I'm thinking about all of our associations that are present today, providers, state government officials, but then also persons at the front lines at the local level making it happen every day. So hopefully you'll take some of these concepts back. That's what state reform is all about. I know Rhett and Jon will be out signing autographs after this. No, just kidding, but really. But I hope that all of you will engage with them exchange contact information. Let them know what's happening in your communities, but we really appreciate both of you being here today. Thank you. Let's give them a round of applause.